This podcast is produced by the Center for Deployment Psychology at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of Defense, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of Defense, or the U.S. government. Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do.
One colleague to another. Welcome back to Practical for Your Practice. I am Jenna Ermold and joined by my co-host today, Dr. Kevin Holloway. Welcome, Kevin.
Thank you. Good to be here as always. Welcome everybody who's listening.
And we are very excited to also welcome our guest for today, Dr. Brian Pilecki. Welcome to the podcast, Brian.
Thanks. Thanks for having me.
Yeah. And if maybe you could just give our listeners a little thumbnail sketch of who you are and what you do and why we invited you here today.
Sure. I'm a clinical psychologist based out in Portland. I work at a clinic called Portland Psychotherapy, where I'm involved in private practice. And that includes providing therapy support to clients who use psychedelics. I'm also involved in research on psychedelic assisted therapy. So the main thing is that we're doing a clinical trial of MDMA for social anxiety, which has started. I also am an instructor for fluence training and generally involved in the movement of psychedelic assisted therapy and what's happening.
And that is why we're super excited to have you, because I think for a lot of us at the Center for Deployment Psychology, but also maybe for a lot of our listeners, most of us don't know a whole lot about psychedelic assisted psychotherapy. So we were excited to be able to have you come today and explain some of what the ins and outs of that, and also really excited to hear a little bit about where the research is. But maybe before we keep going, we've already mentioned the phrase psychedelic assisted psychotherapy. Mm-hmm. What is that? What do we mean when we use that phrase?
Yeah, so psychedelic assisted therapy is really a novel form of treatment in that it's not psychotherapy and it's not medication. It's really the combination of a psychotherapy with the experience that's occasioned by a psychedelic substance or drug. And so psychedelics have been around, forever. A lot of people know that already. They have a lot of historical use. They also have a history in the 60s of being used in medical contexts in the US and other countries. Mm-hmm. And of course, research stopped when drugs were scheduled in the 70s. So we're seeing a resurgence now of looking at the potential for things like psilocybin and MDMA to be helpful with mental health problems.
And can you just quickly, as we're naming some of these, like MDMA, what might people know that more commonly as, or sort of, I don't want to say the street name per se, but what might folks know that more commonly by?
Yeah. So, the word psychedelic is used broadly to refer to sort of any of these substances that produce an altered state of consciousness. Mm-hmm. And the most commonly studied recent psychedelics are MDMA, even though it's technically not a psychedelic, but we'll call it that for today. MDMA is also known as ecstasy or Molly. It's associated with, the rave culture and dancing and loving other people and feeling
euphoria,
good. Feeling safe, feeling positive. And then psilocybin, which is the active ingredient in magic mushrooms. That is another highly studied area of recently. Of course, there's other psychedelics like LSD, mescaline or peyote. And there's many others. And some of those others are being studied now. But right now, MDMA and psilocybin are, on a track to be FDA approved within the next few years.
No. I love that you said that it kind of includes kind of a wide range of things too. I guess, excuse me, as a little bit of background for myself, I do some private practice on the side and have like literally close to zero experience at all with, working with any clients who have taken advantage of psychedelic assisted or even psychedelic experiences. I have one that I can think of in particular who was receiving ketamine treatment as part of like an intractable depression kind of a treatment. So, I mean, it wasn't involved in it, but it was happening kind of in parallel. Would that be also kind of under the same umbrella? Is that kind of a similar thing, or is this a different experience?
Yeah, ketamine is a dissociative drug that can produce some psychedelic effects. So, it's being used in the same model as psychedelic assisted therapy, where the idea is you meet with a couple of therapists or a team and you develop a sense of safety and trust. You're prepared for an experience. And then you have some experience in an altered state of consciousness.
Yeah.
And then there's the therapy follow-up. What did you learn from that? What did you get out of that? And how does that relate to your goals and the problems that you're looking for help with?
I think that's so important because, prior to this experience, I again, knew nothing. Probably many of our listeners have had the same experience. And in fact, if the topic came up, it was almost like, it's just an excuse to get high. How can that be therapeutic? And it's not about just go do this substance and now you're better. It really is incorporated into a larger program intentionally, as part of that treatment. It's not just the thing that's being done.
And that actually leads into something I really want to make sure we talk about, which is, what is the theory, if you will, kind of behind why psychedelics might actually enhance or augment or assist, some of the therapeutic models that we currently have.
Yeah, the therapy is really critical, and that's what we're seeing in the trials, right? And that is often misrepresented in the media. The drugs get all the attention, right? The mushrooms or the
sexy drugs.
And people have this expectation that I'm just going to take mushrooms and my depression will melt away and everything will be better. And they don't realize that there's often a lot of work that needs to be done, and that the medicine can be helpful in that process, but it's not a magic bullet. And so that's, having that accurate expectation is really important. And in terms of how does it work or why does it work? Jenna, that's a great question, which we don't really know from a scientific perspective. So we have several hypotheses. And one of those, let's say for psilocybin, is that it introduces a flexible brain state that temporarily one is able to have fresh insights, fresh experiences, new ways of being with them, their experience, or seeing the world, seeing their problems, that then leads to some positive changes that they make that are the result of that experience. There's other hypothesized mechanisms like mystical experiences, or in the case of MDMA, that with trauma, and this might be, particularly relevant to veteran and military populations, when someone goes through trauma, they kind of lock that away. Those experiences get pushed down because they're too painful. And what MDMA seems to do is they help someone feel safe and relaxed and good enough to revisit and process those experiences that are otherwise. So it's kind of like enhancing the therapy that, the therapy can happen with or without it, but the medicine seems to make it easier in some ways.
Helps facilitate, maybe helps augment it in a way that people can engage with it and benefit from what we kind of think of as the mechanisms of the evidence-based, the psychotherapy side of it. I like that a lot because, certainly probably any of us, but Jen and I and listeners, and you, Brian, any of us that have seen clients, we have certainly encountered clients who, you know kind of what they need to do. They know kind of what they need to do. And for whatever reason, are just, they can't let themselves get there.
Yeah.
Yeah. And I imagine this, can be at least, one potential option for folks that would otherwise, find themselves stuck, not able to engage.
Absolutely. Yeah.
On the psychotherapy side, we obviously have different evidence-based psychotherapies we do. And Kevin and I are prolonged exposure trainers, for example, and we train and do consultation on that for PTSD. And I'm wondering what's involved in becoming more expert in this area. Like, how do you it could be, I imagine it could be an area where things could get dangerous quickly if you weren't well trained.
Right.
So what does that look like? How did you maybe even use your example? Like, what was your path? And I don't know if you sort of supervise or help others along, shepherd others along the way of becoming expert in this.
Yeah, I mean, I've been following psychedelics for 20 years and have been very interested in the field from when I first encountered it back in college. And I guess one thing that a lot of people don't realize is that there are different pathways for different psychedelics. So for MDMA, there is MAPS, is the Multidisciplinary Association for Psychedelic Studies. They're the main organization that's been funding all the research for PTSD. They have a 100-hour training program that you have to go through, which I went through. In order to deliver the treatment that I'm delivering on my clinical trial as a study therapist. So that is actually publicly available right now in anticipation of FDA approval, which will probably be sometime next year. So right now, there are many therapists who are being trained in that. And then once you get the training, you'll need to get supervised on a case. And then you'll be fully certified to provide MDMA assisted therapy. And then psilocybin will have its own pathway. And so, there's a lot of trainings now that are more informational, where you can kind of learn the basics of what this model is. But to actually provide the clinical services, you'll need a specific certification depending on what exactly you're doing.
That's really important. Yeah,
and good.
Yeah, and good. Well, and it occurs to me again, I mean, we've talked about it as, assisted therapy, that there's the psychotherapy side to it. Is there like, particular, psychological therapies that people, maybe should be adept at, have a good background in before engaging in this kind of training too, to make the, kind of round that all out, have the fuller picture?
Based on your podcast, I have a guess, Brian. What do you have to say?
Yes, you revealed my bias. I've practiced from using acceptance and commitment therapy and cognitive behavioral therapy. So that's my what I find useful. I love the question though, Kevin, because the field really has seen a variety of therapy models. And for me, one of the most interesting things is what therapy is the most effective at leading to therapeutic change. And I don't think there's been any real, head-to-head comparison studies, which I think we'll see. We'll see maybe a psilocybin trial where there's two therapy models that are compared to one another, and we can kind of investigate which ones are better.
We're certainly fans of ACT on this podcast, and in addition to PE and other evidence-based psychotherapies, but we're also really big fans of data. So we're looking forward to that data coming out. So,
what about disorders that maybe have the most research supporting use? So there's obviously the types of therapies and the types of psychedelics, but what do we have the most data to support? Targeting this. I'm not going to end this grammatically well at all, so I'm just going to stop. You know what I'm saying?
Yes. And it's important, I think, to understand that we are just at the beginning of the beginning.
Absolutely.
And that we have, these are a couple of trials, very limited data, but they're very strong and promising. Right. So, I think I try to be very careful when I talk about it, because I don't want to over idealize and say, oh, this is great for everything, because there are people who will hear that. But I don't want to minimize it either, because there is a significant trend we're seeing in these studies. But the biggest support right now is MDMA for PTSD. And then psilocybin for depression, or psilocybin for the end of life distress that one experiences when facing their mortality. Those are the big areas. But right now, if you type in psilocybin in clinicaltrials.gov, there's over 100 trials from everything from OCD to fibromyalgia to eating disorder. I think that, the field is wide open, and that's something we'll see in maybe 5 years down the line. We'll get a better sense of what is this good for, and are there particular folks who shouldn't be involved in this, where this might actually be dangerous.
Yeah.
And I think there was something about social anxiety too. Was that MDMA and social anxiety study?
That's our study. And there's been one prior study on a population of autistic adults, but that would be another potential, application.
I was just going to say that I think a lot of our listeners will be providers who are seeing clients in the context of like, DOD military treatment facilities or VA facilities. And so my guess is we're not, a lot of our listeners are probably not ones that are going to be necessarily giving this kind of therapy or having it be part of their typical, therapy toolbox, but they might be, seeing folks who have either already engaged in psychedelic assisted therapy or maybe are currently, receiving that therapy in another place. And so like, what are some of the most important things that therapists, even if they're not the ones giving it, but, are working with clients who are engaged in this treatment? What are some of the most important things they should know?
Yeah, I think, even if you don't plan to deliver this treatment, it's going to be more and more popular. So it's good to get informed about the basics. You don't need to become an expert, but, just attending a short training or, just reading a bit about it so that you can have better informed conversations with your clients. Mm-hmm. And I think it's important that, we acknowledge that there's a lot of stigma around the use of drugs, right. And all of that is present in this. And so creating a space where clients feel free to explore, because if they sense that you're not open to this, they might not tell you that they're going to go do ketamine on the side and they're seeing you. And I think you'd want to know that if they're going to be experimenting or doing things. So creating that non-judgmental space where you don't have to be an expert, but just to have an open conversation with a client about, hey, what did you hear? What does that kind of inspire in you? What are you thinking? And
myth busting too, I think on the, common kind of misperceptions about this treatment. I imagine providers, again, even though they're not providing the care, could also kind of address some of those misconceptions and maybe any of those you see as problematic as this is getting rolled out more.
What are some of those? Like, what are some of the common misperceptions you've encountered, Brian?
Yeah, I mean, I've had clients share with me that, former therapists have, basically taken a very rigid substance abuse perspective, like, well, you're abusing hallucinogens or kind of approaching it from that angle. And, indeed, anything has the potential to be abused. And I think with psychedelics, we don't see a dependence outcome in the trials or in even animal studies. There's not that sort of dependency that we see in other substances. So, it's kind of those kinds of statements around feeling that, psychedelics are all bad and they're dangerous and they make you go crazy and they stay in your spine forever. And a lot of the things that we were, some of us grew up kind of being told with the war on drugs and all that is a lot of misinformation. And I do think there is risk to using psychedelics. It's not like there's these are just, again, they're not magic bullets. And there are, they can be psychologically very intense, challenging experiences. And more so if one isn't prepared or if the set and setting is not controlled in a specific way, right. People can have pretty bad challenging experiences.
Can you walk us through, what does that look like in your study in terms of what, how is obviously these are controlled substances. How is the drug administered? And then what happens? And then when does the psychotherapy happen? Just like, that would be great to see just a snapshot of what that looks like.
Yeah, in the MAPS model for PTSD, there's 2 therapists present for every session. We're trying to cut down a little bit on that to make it a little bit more practical when it does get, disseminated, because that's expensive. But we have 1 or 2 therapists present. And there's the preparation sessions where you're just talking a client through what to expect, what's going to happen, and kind of instructing them what to do when they receive the MDMA. And things like acceptance or willingness, be open to whatever happens, and we're here to support you. And they come in, and then the day that they receive the MDMA, it's administered by one of us, but there's a study physician that is doing medical checks. So we're checking in, we're taking vitals, we're monitoring them medically. There hasn't been any enough in terms of the initial MDMA data to suggest that there needs to be a physician present. It's safe to do without a physician on premises. And then, we're with the client for, 6 to 8 hours while they have this experience. And so it's a long day for us and for them. It's an emotionally draining day. And then we meet with them the next morning. And then a couple of following integration sessions. So it's sort of this pre and post and model that, basically the experience is wrapped around with a lot of therapeutic support.
It sounds initially kind of resource intensive.
That is a criticism of this, is that it's expensive. I think the estimate for MAPS, the PTSD treatment model as it is in the trials is somewhere between $9,000 and $14,000.
Wow.
And that's most of that is the hourly rate of the providers.
Right.
And so there is an accessibility issue here. Like, insurances probably won't be able to cover it initially. And so it'll be only accessible to those who have the resources to pay for it.
Yeah.
Kind of scaling, beyond that too. How do you scale to the need or the population?
I think you touched on this a little bit, but future directions you're excited about as you're continuing to see where the research is headed or the application is headed. We talked briefly about the barrier of resources, but what's upcoming that you're excited about?
I'm just excited for more data, to have more evidence-based, conversations, because so many of my answers to clients or to other professionals is, we don't know yet. And it would be nice to know. It'd be nice to know a little bit more, and we're gonna.
Right.
The real passion for me in this is that, I'm a therapist. I promote therapy. I think therapy is great for so many people. It's life-changing for many people. And there's some people that our current therapies and medications just don't help.
Absolutely.
And so this is a potential other, almost like completely different option that might help people who haven't been previously helped. And that, to me, is the most exciting part of all of this, is that, we're seeing some of these initial trials. Again, they're highly controlled and small samples, but the results are pretty remarkable. That, 67% of the phase 3 PTSD folks came out with no PTSD diagnosis, 67%.
Wow.
And then there was even an additional percentage that got, some clinical benefit. And I think it was only 12% that didn't get any benefit. So that's pretty remarkable.
Yeah.
Yeah. Are these folks that had been in other forms of treatment for PTSD prior?
Most of them, yes. Most of them have been they've been to other therapies and they've tried medication, they've tried therapy. Yeah.
Yeah. So that's 67% of people who had tried other things, the more conventional kinds of therapies that they would otherwise be able to access. So, that's exciting.
It is. Yeah, it's really hopeful, I think. And the cool thing about those studies is that in the placebo condition, I forget what it was, but maybe about a third of the people also didn't have their PTSD diagnosis at the end. So, this is the problem with doing the research with psychedelics. Can you imagine an 8-hour therapy session with a placebo?
Right.
but
very intense, perhaps very effective.
Yeah. You're just, it's kind of a weird thing to think about. But basically I'm bringing this up because I want to, again, emphasize the role of the therapeutic support, and that this is a little bit of a different model. I'm an exposure therapist. I'm a CBT and ACT therapist, but this is a little bit different way of approaching things that might, again, help some people that traditional therapy hasn't.
That's exciting. Thank you for being here. It's one of those things. I know as we were talking about this and planning for the episode, we're kind of like, man, we want to ask good questions. We don't want to sound stupid, but it is kind of one of those topics that sometimes people already have feelings or expectations, or like you said, stigma about. So we appreciate you kind of explaining it a little bit to us, kind of at the basics. We like to end any of our episodes with what we call actionable intel, which is maybe a couple of points. What are some things that our listeners can like take from this episode and like do right now, something they can implement right now, or things that they can go read more on about this topic, or any suggestions that you might have to any of our listeners, what they can do following this episode?
Yeah, I would say, the one thing is if you don't know anything about this, is to start to educate yourself. And I don't think it matters too much where you go for that. You can take a training and get a couple CEs. You can, listen to some podcasts. You can read a book. I think Michael Pollan's book, For Better or Worse, is a good, introduction for our current times about what this is all about. He kind of went in more objective and I think gives a balanced perspective. There's some flaws with his book, but overall, I think just starting to read and to just examine your own bias and see what's present for you. We all have them. Even if you think you're favorable, like there's probably some hidden biases. And, for example, I'll often ask clients in my, substance abuse history, I'll ask them, even if they're not coming to me for psychedelics, they'll say I did acid a few times in college, and I'll ask them, well, what was that like for you? And very often they'll say, you're the first therapist that's ever actually asked me how it went. That didn't just like say, oh, that's box, okay. Right? Yeah. Okay. So just to be curious and to be open and to be willing maybe to look at your biases and try to establish that non-judgmental space with clients, because they're going to probably do it anyway, whether or not they tell you. And I think it's better that they tell us if that's an area they're exploring.
Yeah. I was going to say earlier, the judginess doesn't necessarily preclude what our biases are against. It just means it just cuts off conversation, cuts off communication.
Exactly. Yeah.
Yeah.
And we can definitely link the MAPS training in the show notes. And if there's any others that you think of, Brian, we can certainly link those. We'll give a shout out to check out your podcast as well.
Yeah.
What is that called again?
Altered States of Context. It's a podcast on the intersection of psychotherapy and psychedelics. So we dig into a lot of these issues in more depth if you'd like to check us out.
I think that's great. If you wanted to listen to a podcast, seems like that's one that's got a lot of good content. So
I suddenly have a lot to listen to and to read. So I'm excited.
And maybe someday, Brian, we can get you to come back and give a longer webinar on this, because we have a series on that too. So we'd love to maybe have you back in another capacity if you're willing. But for now, we will definitely thank you for joining us today, and best of luck in the research that you're doing and the clinical work that you're doing. And thanks for really leaning into this part of the field and trying to get some good data and answers to these questions that lead to more questions, it seems sometimes too.
Indeed. Yes. Well, thanks again for having me. It's been a pleasure to chat with you.
Yeah.
Great to have you on.
We hope to see you next time on Practical for Your Practice, and have a fantastic week, everyone.
Thanks, everybody.
Thanks for listening to Practical for Your Practice.
Please feel free to subscribe, rate, and join in on the conversation in the comments.
Until next time.